So we'd like to invite Dr. Advani sir to chair this session and Dr. Kumar Prabhas sir. Sir, uh, so I would like to invite Dr. Saurabh Bhave, who is consultant bone marrow transplant and CAR T cell, SANACT in Thane, and he will be discussing about cases in myeloma. Can somebody keep a mic with Advani sir so he can give expert comments? No, no, no. So the panelists for this myeloma are Dr. Bhauseb Bagal sir is online, Dr. Jayan Kawande, I would like to invite, Dr. Girish, Dr. Bilal Kazi again is online, Dr. Nakul Joshi and Dr. Shruti Toshnimal, and I would like to invite Dr. Nikita Mehra.
So who all are? Nikita is here. Nikita, please come. Bahu Sahib is online. Online. आ गए हैं sir? He's online. Hi. Quick, quick, quick. 10 minutes. Girish is already on the die. Shall we start? Shall we start? So we have a 68-year-old male, a case of ulcerative colitis, controlled on oral treatment and benign enlargement of prostate on treatment. Multiple myeloma diagnosed 2017. At that time, fish was negative, IgG kappa, ISS stage 1, VCD into 4, autologous stem cell transplant in July 2017, and after that, lenalidomide maintenance. First relapse in 2022, 5 years down the line. Given VPD, again remission till August 2023. Then he had a second relapse. Treated with daratumumab plus carfilzomib plus dexamethasone. Received a total of 24 doses of dara till August 2024. Third relapse in August 2024 while on daratumumab. At that time bone marrow was done which showed 35% plasma cells. Fish had a new clone in the form of deletion 17p and a gain of 1q. PET scan showed multiple bony lesions, organ functions okay, performance status good. Treated with carfilzomib cyclophosphamide, which was complicated by a fungal pneumonia, treated with voriconazole, and the fungal pneumonia improved. So question number 1, anyone can take up. He is a relapsed refractory myeloma, post auto HCT and DARA exposed, has a new clone in the form of 17p and 1q. So what are the treatment options available? Nikita?
All right, sir. So, I'll answer.
Yeah, Girish, no problem.
So yeah, he has been treated with multiple lines of 3 lines of therapy and has received monoclonal antibody as well. So probably we have an option of giving something like VTD pace because it's been aggressive disease and there is clonal evolution as well. Along with that, we can consider him for CAR T cell therapy, and teclistamab probably can be a option.
So we have huge options. We have 2 antibodies, we have ADC, we have 2 CARs, we have teclistamab, elrantamab, talquetamab, we have bendamustine, VAD, VTD pace, we have oral drugs, we have MPT, we have selinexor, and there is an option again for an second auto HCT because it is more than 3 years after the first auto HCT. So huge number of options. So things are becoming difficult to decide which is the best available option. So Nikita, what will you do? How do you choose a treatment?
So of course, so can you go back about 2 slides?
Sure.
Previously, I'm sorry. So the first relapse was about 3-4 years later, and the second.
5 years later, first at every relapse, one year down the line.
Okay.
So shorter and shorter remission periods.
Okay. Okay. So refractory to daratumumab also.
On DARA, auto, BOT, CART, cyclo, LEN, DEX.
And the performance status of the
Pomalidomide,
patient.
very good. Good performance status.
Okay.
Even though 67 is quite okay. Organ functions are good. The ulcerative colitis is okay. BEP is okay. Absolutely fine. He doesn't have peripheral blood plasma cells. No other organs involved. No extramedullary disease. Only in the bones and marrow.
Okay. So, of course, of all the options that you showed, what is practical? Oral melphalan, I'm not sure. I mean, yes, you could give that as well because the patient has had a transplant and has done well, but we do use some bendamustine. And we have had some patients who've responded for a brief duration. Again, these are anecdotes. They're not lots of patients who've responded well. But because of its dual anti-cancer activity, it possibly has some immunomodulatory role. So bendamustine is something that we shouldn't forget. Aside from that, a transplant, we actually have a couple of patients at Cancer Institute WIA where patients with refractory disease have been transplanted. We wanted to ideally take them up for two transplants, that is a tandem transplant, but we were not able to get funds for them. And they've done all right. So practically in our center, I mean in our country with limited resources, etc., that can always be an option. And again, this is something, there's published data on actually giving a smaller dose, international data, on giving a smaller dose of IV melphalan. You don't even have to give 200 milligrams per meter square. Sometimes stem cells, storing stem cells, we won't be able to yield enough stem cells. So you can give smaller doses. Those are the only practical
Nikita, he
options.
has all the money on earth.
Teclistamab.
Money is not, here we are not in economics. Huh? This is all money on earth available. No problem. Then what will you suggest? Absolutely well. He has come to you with some hope. No melphalan, selenexor, VTDs and all out. So what will you consider for this with a new clone which is 17p and 1q gain and penta-refractory?
No, of course, sir. If CAR-T is available, if you could, if we could refer the patient to your center for CAR-T, we would.
Vijay, achieved. Mission achieved for today. Huh? Absolutely right. So there are antibodies, there are ADCs and there are CARs. If you have everything on earth available, currently these are the three options available. If you can go to any center which will offer CAR, and we are offering CARs, plus antibody or ADC, whatever we are offering. You can have a clinical study or you can use others. But this is money unlimited. Lakshmi ऐसी खड़ी रहनी चाहिए, मुट्ठी बंद नहीं चलती है. But that is available. You have lot of patients. So don't underestimate the money power in India. The way we are investing in SIPs, you should understand. 25,000 crores a month, that much money we easily have, right? So these are the 5 BCMA approved therapies into 3 classes: CAR-Ts, T-cell engagers and ADCs. And probably if you look at the literature, CARs are the best currently available. Even though the data are from single center, the Mayo data, 350 patients, long-term survivors, less toxicity, less cost, less infections, CAR-T do the best. See this. This is about CARs, this is about monoclonal antibody, these are about ADCs, and the blue ones are the stringent and the CRs. See the number of CRs in CARs. So probably if I have 1 crore and I cannot afford more than that, instead of going to anything else, I would prefer a CAR. That's the current message which I got 8 days of reading literature. So thanks Vijay. I could read some literature. See the infection rates. CAR-T has the minimal infection rates, and that over a long period of time, 550 days, 2 years. Monoclonal antibodies, even you continue to give, the infection rates continue to increase. But CAR-T infection rates drop down. These are the survivals. Across the board, extramedullary disease, plasma cell leukemias, penta-refractory, high risk, on all cases, CARs do better than monoclonal antibodies or ADCs, right? Right. So Jayant, is there a patient population, even though he has a lot of money, you will say don't do CAR? Do you have any such data available or information available? Or anybody can answer. Everything I have available, do you say namaskar, kuch mat karo, ghar
Patient is not fit.
Absolutely. Fitness, most important. Rapidly progressive disease. Very, very tough. Girish, will you say some namaskar to any patient, go home, die peacefully? Even if you have money, donate. Donate to someone.
Yeah, if the patient is not fit, one thing. The second thing is if the probably the expression of BCMA is not good, where we see that there is it is going to not helpful for this patient, then there is no point in offering this treatment for
Right.
this patient.
So still at the till the last moment you have the option of saying no or go home. Otherwise, more or less, probably we should go ahead with some T cell therapy and probably CAR if it is easily doable, available, affordable, and understand. I thank a lot. Asha, I finished in 10 minutes.
So can I add one
Yes,
last
yes,
point,
Nikita,
just very
absolutely.
quickly? So this is a publication by Sameer Hadid from, I think he's from Kansas, US. And they basically presented or published data on the patients who were enrolled on clinical trials for CAR-T but actually did not make
Yes.
it. And they talked about that profile and how many patients died during the wait
Yes.
period.
Yes.
So if it can be manufactured quickly and given
Yes.
great, there are
Probably for
some.
that patients bridge with the antibody or ADC if manageable, and then you do the harvest. It takes 1 month. You do something in between. That something is challenging, but do something and then give a car. But probably if you want to give one, probably currently car is the best available option.
Yeah, and just want to say because we discussed that BCMA expression probably goes down when they are treated with different lines of therapy. I came across a study where ATRA can be used to increase the BCMA expression, so which can be
On the plasma cells.
on the plasma cells, and then we can subject them to BCMA.
Right. Babu Sahib, are you online? Babu Sahib? Doctor? Dr. Shruti, you're online? Am I audible? So what shall we do? Okay, I thank the audience. I thank the panelists also for inviting me. Thanks a lot.